I'll get through this. All right, very good. So let us go. We'll go back to where we were. I just want to get as much of this blood, the basic blood stuff done as possible without going crazy over it. Yeah. And if I can get through the red cells and the white cells, and because understand anemia is a big deal. And I'm not, when I tell you how extraordinarily ill I was, it was just remarkable. I mean, and very, very difficult. So this is kind of where we were, and again, following that, but really getting into what causes them. So surely the interesting thing about chronic is is your body continually replenishes, and the difficulty is that over time is really where it ends. What happens with my case with that chronic, I mean, you're able to, but all of a sudden you're just fatiguing so easily. And I was making a transition at that point in my career from practicing full time, and I was teaching part time for Roche here, both in the North Hills, out in New Kensington. Oh my God, I was, I don't even know how I did it. I got to the point where I just couldn't continue. So I ended up, I was so sick, I ended up in the hospital for 9 days to get me strong enough so I could be out for 3 days, and then I could have my surgery meeting for another 9 days. Not smart. So the iron deficiency so common. Again, microcytic, hypochromic is the way we describe it. Small and pale. Iron supplements. Look for either glycinate or gluconate. Sulfates tend to, if you have trouble, stomach related issues, you got to be careful, though they're more easily findable. I use like that with that Nature's Bounty stuff. I buy them online, whatever. Easy. This is one where we left that before. This is kind of what I thought I had to some extent is a variant, probably because I don't know if it's so much about the intrinsic factor post operatively or maybe just a limitation. So it's famously called pernicious anemia. There was a lot of folks, and so here you can see it's an autoimmune disease that typically is the cause. And your stomach, one of the things your stomach makes, by interestingly, the cells that make the acid, the parietal cells, is intrinsic factor. Without that, you can't absorb GI, you can't absorb B12 from your gut. You can, there's other way you can get it injected, nasal gels. It's not that you can't utilize it. Okay. And so, and it's less of a problem with vegetarians are a problem. Vegans are a particular problem because most B12 supplements are animal derived. And people who are serious vegan have to be, they have to source that, if they feel committed to that. And many do, to be fair. I've got now three vegans, three of my five stepchildren are vegans for fairly long periods of time. You don't have to worry about anybody grabbing the steaks in the house. But I digress. Okay, and so those are macrocytic anemias along with, but remember, pernicious is a common name. You always hear that. And then again, this is what we see a lot with diabetics. They very often have companion. This is the lack of EPO, very common. Yes, renal disease, but the most common source of renal disease, as we said before, diabetics. And yes, this has been around. I mean, I had patients injecting themselves 35 years ago with some of the early GMO, what we call biologicals now. Basically we're making various types of proteins, polypeptide agents, and EPO would be one. This one's unusual and relatively rare and very famous. It's called aplastic anemia. So it's less about the red cells than the white cells. And again, with people who make up the PowerPoints, sometimes they don't know the chronology or the history of this quite well. Yes, I'll buy that there's not enough because it's suppressing your bone marrow. There are a lot of things that can suppress your bone marrow, either accidentally or intentionally. Radiation, okay, viruses, I'll buy all of that, chemicals. But the one thing that we see that does it a lot It used to be a really problematic side effect of the early antibiotics. Famously, back in the 60s, where we didn't have a whole lot of choices for antibiotics, they came out with one called chloramphenicol. We were still using it when I was a resident. So, I mean, it was still being administered in the late 70s. It was a very useful drug for people who were allergic to penicillin. So it would attack both gram positives and gram negatives, which made it a really good drug, okay, and very efficient. The good news, there were a lot of cases of bone marrow suppression leading to death from aplastic anemia. So it really, and it's not the only agent. We were using an oral agent for fungal infections, also led to this, called griseofulvin or fulvicin. So that was commonly used. So you had to be very, very watchful. So aplastic means really it wasn't so much the red cells. What happens? People were dying of infections because you have considerably more red cells than white cells. So it was less the anemia and the fatigue and the weakness, and more of the inability to fight infections that were the cause. So, and yeah, clotting, but the immunity defects really were that. And again, now this was in the age before we knew any. It was, if anything, stem cells and bone marrow transplants were in their infancy. Okay, now those techniques are much more commonly done, where they actually quote unquote sterilize bone marrow. So they basically cleanse the bone marrow and make it facilitated by injecting new bone marrow from a compatible donor, which has become a really a more common practice than you think. Now, when you talk about hemolytic anemias, it means the red cells are being destroyed before they should be. Surely, again, there's certain disease entities, viruses will do that. Incompatible transfusions, when we get to and review the transfusion stuff, okay? And these are some other ones that are the heritable ones. So I'm sure you covered sickle cell in genetics, assuming that you've had that already. Did you talk about thalassemias, which are known as familial Mediterranean anemias? They are more common in folks of Mediterranean, so Southern European, Northern African descent. Okay, and there's a whole lot of variants in there. So there are ones that are comparatively. In the old days we called them minor and major thalassemias, and they were nasty, and they affected different areas of blood formation. That's so much I can tell you about them, but it affected the globin chains.
I remember, yeah, we talked about it.
Usually one of those ones unless you're working with a population, if you're working in that area, or you're working in an oncology hematology clinic, then you get a whole lot of exposure to that type of stuff. Interesting. But now everything kind of changed with the modernization of medicine, where we can basically have advanced ways to treat it. And certainly, wherever you're going, knowing about sickle cell, and this is the distinction I talked about before between the disease and the trait. For the longest time, nobody made a big deal of, oh, I have sickle cell trait. It was only significant if you're getting married to somebody else with a trait, so you knew your risk of having somebody with a disease. Okay, now we know the trait, just like the Ryan Clark, and he's by far and away not the only. I mean, he ended up near death. There was a kid I remember it was at CFU, Central Florida in Orlando, and they had a very aggressive coach who had a bad history of, some kid had the trait. They didn't, and they knew he had the trait. And he's like, Coach, I just can't do it anymore. You're being whatever word that you want to throw in there that would be pejorative. Probably having something to do with a small kitten. And Jordan, I thought that was funny. And he's got this guy running, and the guy died. And there's a lot of cases like that. That one was a big player. A lot of people read a lot about sports. So thalassemias, Mediterranean, one globin chain, thin and delicate, many subtypes, And so transfusions are one way of dealing with this. There's other factors that you can use. Sickle cell is the one amino acid famously. And what happens during exercise, and we thought it was just a disease, we know it's the trait, block small vessels, very painful. The pain, particularly because as it got into the capillaries and organs, people's spleen would rupture. They get pain in a variety of their heart notwithstanding. All of those types of things with exercise. I think I told you I worked a clinic. Maybe I didn't. When I was doing the summer before I got my doctorate, and the summer before that at the Vets Hospital, working at the Medical College of Virginia and their medical school, okay, which is VCU, Virginia Commonwealth University. And my mentor there, the guy I was doing my program with, he ran the sickle cell clinic. We did almost all wound care because the skin was being damaged, but the pain was significant. We were doing mostly wound care. So typically African malarial belt and their descendants, that's the whole idea. Malaria attacks or modifies your hemoglobin. So even though it's a disease that certainly can be life-threatening and frequently is fatal, okay, as you can see, killing 1 million people a year with sickle cell anemia, the distinction is they're no longer susceptible to that disruption genetically. So as you can see, people with sickle cell do not contract malaria. Individuals with 2 copies of hemoglobin S can develop sickle cell anemia. Individuals with only 1 copy have mild disease and better chance of surviving malaria. So what happens in sickle cell? This is the problem. Now we use nitric oxide because we're going to unclog vessels. Fetal hemoglobin does not sickle. So this was a treatment that had been around. I'm not that familiar with. Now it's a lot more of bone marrow and stem cell related transplants. And gene therapy, I do not know how effective that has been. Gene therapy is effectively using a retrovirus to resequence the genetic cells that at the hemoglobin level. I do not know if that is successful or not, other than whether it's commonly practiced or not. And a classic picture you see of the difference between a sickled red blood cell and a normal red blood cell. Flip side is the thick ones. They're called polycythemia. Okay, and again, the whole blood doping and blood viscosity thing that's there. So it's a real problem. What is rare is polycythemia vera, which meant true polycythemia. Okay, extraordinary, and it's certainly bone marrow cancer in origin. So you have to effectively bleed people. To some extent, you might basically remove, spin down the blood, remove cells, re-inject plasma, a series of auto transfusions. That would work. It's kind of the opposite of blood doping. Taking out blood, concentrating it, your body will replenish that blood, just like you going and giving blood. Here at a blood drive, a couple hours later, you're not suffering from it. Overnight, you're back. Versus this secondary polycythemia, what we see at altitude, what we see with performance enhancements with the excessive or needed APO, and then the blood doping stuff that's there. Very, very interesting. Endurance sports, and that's always been the problem. I think they vacated, at least in my recollection, in the last 30 years, maybe 10. Armstrong had 7. 2 of his teammates won, and another guy from Germany who was always against. I'm trying to remember his name. Okay, we'll do some white blood cells and be content. White blood cell. Oh, you'll love this. I love white blood cells. Leukocytes. Again, they're not white because they have a lot of pigment, particularly when they're stained, but they're not red. So in the absence, they call them white blood cells. It would have been a better name for non-erythrocytes, but I digress. 1% of total blood volume. There's not as many. When you're looking at 5 million to 4.5 million to 5.5 million per microliter of red, you're looking at 5 to 11,000, 4.5 to 11,000. Depending on the hospital labs, they're all different. And they are basically the soldiers, if you will, of your immune system in many ways. Your white blood cells travel by way of the bloodstream. When they exit the bloodstream, they may stay the same or they may change. And whether they stay the same or change, they migrate into tissue spaces and areas close to where potential infections are located. So it's well understood a lot of what they do, but not completely so, to say the least. So they're very interesting. And what happens when something creates inflammation, cellular damage, and cytokines, chemical signaling agents, are released, when those contact capillary walls, what they do is they work indirectly. Those chemical agents don't pass through the cell lining. They basically, the membrane, so they work by a G protein mechanism. And effectively what they do when they attach, they cause internal changes. So they attach on the outside, and what happens, protein, I hate to say markers, but protein strands change shape in such a way that they protrude into the bloodstream. So what happens, here's the blood in the bloodstream. White blood cells are slower than red cells. They're heavier than red cells. So the red cells are in the center, the white cells are on the periphery. What happens when these basically protein appendages change shape and protrude, they latch on to white cells. Okay. At the same time, those chemical agents cause the tiny clefts in capillaries that have clefts that can adjust size to open. And basically, so they move through the tissue spaces by a amoeboid motion, positive attraction of chemicals. And what happens is, if it's like a limited space, they can sort of, they don't need a giant opening to walk through. They can kind of, diapedesis means they almost change, they sort of scooch through. Like sliding a paper under the door. I always think of the mummy, where remember Brendan Fraser. I saw the guy in Mummy 2. It was a pretty good show. I'm trying to remember the show.
Oh, those movies used to scare me.
Oh.
The Mummy movies used to scare me.
Oh, you should go back to the original one, 1931. Mm-hmm. Boris Karloff. Edward von Sloan, yes. Loved it.
That's probably a lot worse.
Oh, and was it Zora Lampert? It was the same people who made Dracula. It was the same production team, but not. It wasn't James Whale who made Frankenstein and Bride of Frankenstein. And the Invisible. It was great. And he's like, so here's this mummy, and he said, I want to shake your. I don't care to be touched. It looked just like he had this Frankenstein look. It's great. Otis B. I have to go watch it. Moving on. So the diapedesis is sort of squeezing through the cracks and moving along. So if your white count starts to go up above what your typical normal is, and so in a hospital, which is, again, it's a snapshot, you start seeing 11,000, all of a sudden you go, something's going on here. So it's perfectly normal. If somebody comes in with it, they cut themselves and start to get infected, you would expect to see that. It's just a criteria that says, okay, I've got to go treat this. And the reality is, we look at the white blood cell count to specifically identify, are we dealing with bacterial or viral infections? That's why it's so important. When you start looking at typical CBC, complete blood count, okay, involves a lot of things depending on the hospital, but at the very least, red count, white count, so the absolute count, okay, hematocrit, that thing, that percentage of volume by blood, and hemoglobin, and normally what we're going to look at now called the differential. That's what you were going to do in the lab. Differential is being able to now, obviously with automation and advances in technology, we can do it very, very accurately. But it's a way of looking at those cells to determine if they're in the appropriate proportion or not. So we have two families. Again, once the cell line commits, it will commit to the white blood cell line, and it will either be granulocytes, meaning we have granules that stain and you can see them, versus agranulocytes, which means we can't see them. So we to some extent erroneously call them without granulocytes. They should say without visible granules, but it's easier just to go with the flow. Visible cytoplasmic granules. So neutrophils, the most common, eos and basophils, eosinophils and basophils, based on how they're staining, okay, are the least common, and in the middle are what we call the mononuclear forms. When you hear about mononucleosis, it doesn't mean, it implies that there's a lot of monocytes, but really what it implies is there's a lot of mononuclear forms, which means lymphocytes and monocytes. And if there's one easy acronym that actually works, it's this one. Though I think it's cruel to the monkeys. Never let monkeys eat bananas. It's not quite like never let elephants eat peanuts. You know how they like peanuts? What happens when you mix an elephant with peanut butter? Peanut butter that never forgets, or an elephant that sticks to the roof of your mouth. That's before we use swearing in jokes.
Do you tell Badger that joke?
No.
He likes elephant jokes.
He does?
You know his elephant in the red toenails joke?
No.
Why does an elephant paint his toenails red?
I don't know why.
Behind a cherry tree. Or cherry bush, whatever.
Okay.
He tells it better than me.
See, there's always, it's not fair now because we don't, hunting is like, big game hunting is wrong. This was Groucho Marx in Animal Crackers in 1931. So he was the great African, he wasn't, but he was trying to get money off of the dowager, the rich lady, Margaret Dumont. And he came in, his name was Captain Spaulding. And it was a great song, which was his theme song. Hooray for Captain Spaulding, the African explorer. Okay. And he goes, I just shot an elephant in my pajamas. How I got in my pajamas, I'll never know. See? Take my wife, please. The greatest of all the one-liners. Take my students, please.
That's messed up, Dr. Stein.
So, neutrophils, lymphocytes, monocytes, eosinophils, you can't forget it. That's the batting order, from the most to the least. And they do different things. So when we look at that area of leukocytes, on average, assuming that you're doing a simple count, okay, as long as your neutrophils are 50 to 70% normal. Eosinophils and basophils, very few, 2 to 4 for eos, less than 1% for basophils. The agranulocytes, the mononuclear forms, lymphocytes 25 to 45, monocytes 3 to 8. That's normal for a differential. So if a basic differential is like that, you're happy. This is what they look like. It has to do with the staining. So neutral is either red, I don't know how the blue shows up. Basophils stain blue, bluish purple. These are red granules. Eosins are reddish stain. Neutrophils stain what they call classically a lilac color. I don't know what that is. You can tell me if that's lilac. I mean, lilac's a flower. It's like, oh, it's orange color. Orange fruit. I like it as peach, salmon. It's a fish. But normally they have basically neutral staining. That's where they get their ideas. The lymphocytes all stain that bluish purple, as do the monocytes. The monocytes are the largest. You know them by their size, and you know them by that sort of U-shaped or kidney-shaped indentation. Lymphocytes, because the nucleus nearly almost appears to engulf the cell. The granular forms, neutrophils have 3 to 6 lobes. Eosinophils 2, basophils 2. It's not, they call them erroneously multinuclear forms. They are not. So it's like one big nucleus that's folded, like a balloon puppet. It's always the analogy I use. Mine always blow. Balloon puppets?
Not good at making blue.
Did you ever have balloon puppets in first day? I know. Explains it all right here.
You think?
Yeah,
Probably.
if you got balloon puppets, you'd be different.
You think so?
Yeah. So if you see 3 to 6 lobes, you got a neutrophil. You see red granules, got eosinophils. You see purple granules, mistake students make. They look at these, oh, it's a basophil. No. Basophils are distinctly filled with granules. They're hard to find. When you do that in lab with a peripheral smear, they're hard to find. Okay. Enough said there. So they're larger, the granulocytes are larger and shorter lived than the red blood cells, lobed, not circular. The stain we use is called Wright stain. That's the typical stain we use, proper name, and they're all basically phagocytic. Neutrophils, a lot of different names. Neutrophils, polys. The formal name is this: polymorphonuclear leukocytes. Variety of different nuclear shapes, white blood cells, how they derive their names. So you see all of those things. All of these cells have immature forms. The same thing with anemias and reticulocytes. If you have immature forms trying to fight infection, you're losing the battle. The only time you might see immature forms is if you're in the first stages of a very acute infection. If they're not there and then all of a sudden they manifest themselves, it means that that battle is being lost. Why? Because your body's saying, release more. I'm not, chemicals are being released, summoning more white blood cells. They haven't matured fast enough in the bone marrow and other areas, where they're associated. So it's sort of like fighting a war with soldiers that haven't been trained properly, would be the kind of analogy. So as you can see, they're about twice the size of the red cell. They stain with both dyes, acidically and basically, and therefore that gives them neutral. There's a lot of things that are in there, a lot of chemicals in those granules. Okay, they're and we see them elevated in bacterial infections. That's the biggest single note. We call that a shift to the left. When we see an increase in white count with an increase in the proportion of neutrophils, it speaks to bacterial infections. So what they do, all those toxic derivatives they make inside the cell, bleach, hydrogen peroxide. And so what happens is when they engulf it, you're going to see that these little defensins poke holes. Very scientific. It's like I'm going to pop holes in the bacteria and shoot nasty stuff in there, which is pretty clever for a single cell. You got to give it to it. I wouldn't have thought of that. So here they are up close and personal. EOs, relatively small proportion, 2 lobes, like earmuffs, if you will. Those granules, and so we see these elevated in 2 things. Parasitic infections. You can call a virus or a bacteria a parasite. In this context, parasitic infections typically are things like eukaryotic parasites. So worms. We'll see it raised if people get contaminated water with giardiasis or amoebiasis, like we would get from contaminated well water. Those types of things, bad water supplies. those people have eosinophilia. Also, people with allergies and asthma and different kinds of immunological responses. My middle one had what was called eosinophilic. He had, they talk about irritable bowel and those things. They did a workup for him at the Old Children's Hospital many years ago because he's going to be 40. He was like a year and a half. And when they took a biopsy in the gut, he had masses of eosinophils. So he had a lot of different food allergies that more or less have gone away over time. It hasn't stopped him having, some trouble with his stomach, but by and large gone away. What they do, those enzymes, worms are quite large, so the enzymes basically start to because worms are really just large in segments. It's almost like they're starting to destroy them segmentally, and then the rest of your immune system can take over. Basophils, rare. You're lucky to see one. If you scan a slide, typically purple with one or two constrictions. Typically, they're bilobed. Basophilic granules, and they all have histamine. These are the linchpin of asthma, of anaphylactic shock, of a lot of allergic reactions. Okay, they are very similar to when we get to the immune system. We'll look at, because basically what a basophil does, when it leaves the bloodstream, it basically changes into a mast cell. Same cell, it's got a different name. It's just like you're going to see when we talk immunology, a lot of lymphocytes turn into what are called plasma cells, little factories to make antibodies. Neutrophils stay as neutrophils. Eosinophils stay as eosinophils. Okay. Basophils change. Most lymphocytes stay the same other than the ones that become, basically produce large amounts of antibodies as plasma cells. And the one that also changes is famously the monocyte, which becomes a macrophage. So you should remember all those transitions. Here's the basophil. So the mononuclear forms because they don't have a nucleus that's in segments, lymphs and monos. Lymphs, second most common. When you see an uptick in lymphs above 45%, almost like flip-flops with neutrophils, rather, that is what we call a shift to the right. That suggests a viral infection. You'd have that with COVID. You would have that with a really bad cold or flu presentation. That's typically what you would see with that. So the nuclei, you have that thin rim, of cytoplasm. They're in nodes in the spleen. The ones in the blood, and you can't tell the difference, are either T cells or B cells. We'll get to the distinction. T cells mature in the thymus, where B cells in the bone marrow. And you're going to see that they different changes. That's all immunology. So and most of the time, the ones that you see in a peripheral smear are either T cells, and sometimes if they're close to like the skin or a lining, they are what are called NK cells, which we'll get to, which are natural killer cells. They're somewhat non-specific T cells that act like killer T cells, which we'll get to. Monocytes, a whole lot more cytoplasm, fewer kidney shape, change into macrophages. They're the big players. Whenever we're gobbling up the debris that's there, whether it's viruses, bacteria, chronic infections, they play a role in activating lymphocytes as well. They're part of that network where when they phagocytize, they may release or be what we call antigen-presenting cells. They may gobble something up, and in the process of gobbling it up, take one of its markers, its protein appendages with a short chain of carbohydrates, and present that to a B cell or typically a B cell to activate. We'll learn about the single most important cell in the immune system, known as the helper T cell. That's the one that's clobbered by HIV. So follow a lot of that, and there you are. So basically, we're going to get into, again, with immunology, we'll talk about interleukins and colony stimulating factors. These are the chemicals that are released by members of the white blood cell community, and particularly by tissue damage. So interleukins, we've learned a lot. We used to only know about a couple of them. Now we know about 20 of them. For a long time, I was taking Cosentyx, which was blocking the action of what's called interleukin 17, which is a pro-inflammatory agent. Fairly hard to tolerate that. I'm now getting off the biologicals. Going back, I'm going natural and healthy.
Are you?
Yep. Yeah, I feel better. Hey, she started again. Every night before I go to bed, we're watching TV. She brings me a bowl of supplements. Vitamins, biotin, minerals, vitamin D, iron, everything. And if I say I really don't want those, it's rather, the usual. You'll take those. I have regard for my health. That's physical damage. So we'll get into all of that. So again, we're going to look at the pathways. It's 2 lines. So granulocytes, they go through a whole thing. This is what we look for. When we start to see band cells, and all of them have band cells are immature. You'll see on, I'll pop up, maybe Wednesday, because I'll have to I don't have the password handy. My UPMC, where all those are. So as you can see, they're in the bone marrow than in the blood. 3 times more white blood cells are formed than RBCs because white blood cells have a shorter life. Cut short because when effectively it's a battle they really dead white blood cells are when we see pus, it's dead white blood cells. Pus is dead bag. It's not where the infection is. It's what's left of what the infection was. Dead bacteria, dead tissue fluid, dead white blood cells. People erroneously take samples of pus and try to culture it. We have a word for that in medicine. Lazy. I'll just take over the dressing and culture drainage. That's criminal, as far as I'm concerned. That's malpractice. But it'll hurt if I have to swallow it. Who cares? Pre-medicate the patient. Idiot. Okay, these live a bit longer, as you can see. Okay, and then we'll get into the different precursors that are there. This is what the lines look like. So depending whether they're going into the myeloid or lymphoid line. Why are those names important? Because cancers of this line have a particular name. They're called leukemias. Emia means too many. Penia means too little. We have leukopenia and leukemia. You can either have myelogenous, that's the granular line, or lymphocytic, that's the lymphocytic line. Leukemias. They are different. They're treated differently, and you have 2 variations. You have acute, which is very dangerous, and chronic, which is a little bit easier, not desirable, but easier to treat and more survivable. The chronics are more common in adults. The acutes are more common in children. So a lot of these. So we can try to, there's all sorts of techniques that are used. A lot of these different factors, and I'm not up on the science that has to do with it. This is when you get to speak to somebody in infectious disease who would have a lot to share with you about that. They're very good. Infectious disease specialists. So leukemias and a viral infection like mononucleosis. Leukopenia, typically what we see a lot of with cancer chemotherapies. Glucocorticoids we talked about. So like cortisone is a good news, bad news thing. When you're using cortisone agents, well, it suppresses your immunological response. Asthma, using it because you have an autoimmune disease or an immune system is sort of on hyperdrive may be useful. The trouble is, it's a general suppressant. So it's going to suppress ways that you might choose to protect yourself. He's still calling me. What does he want? Doofus. Okay. Leukemias, again, typically cancerous in the bone marrow, single cell lines. Again, you see the difference. Acute, typically stem cells. Chronic, probably more when it's already in the proliferative stages. And that's broad brush painting, and I wouldn't recommend them for either. That was some of the earliest cancers when they started to look at them. Leukemia has been around for a long time. Okay, so, well, I mean, you can see all the things that it does. When they fill the bone marrow, you know, platelets, you hemorrhage, you're unable to, because even though you have an abundance of these cells, they're not healthy cells. They can't fight infection, so it's just fraught with danger. This is, I just did the virus unit for my micro classes. EB, Epstein-Barr. A lot of people have Epstein-Barr. A lot of people have been exposed to it. Okay, it doesn't mean they all got mononucleosis, but a lot of people have been exposed to it. Okay, so they named it mononucleosis, but the reality it was mononuclear forms. And the problem is it compromises your immune system and it causes your spleen and your liver into overdrive. And what happens, they get enlarged and they're fragile. And the big problem is when people would have young, healthy people like you, and you're in the age group, would have mono. 2 weeks, I've been stuck inside for 2 weeks. I want to go outside. You know, I want to hang out with my friends. I want to do some sports. And you get into touch football, and all of a sudden you go down. You could rupture your spleen. I mean, so you've got to you have to understand the ramifications of going back too soon, and that's where people don't. And the older you are, because it can be, once you have it, you have it. And so I told them this in micro. When it recurs as an adult, you're really sick. My first wife got it more than 20 years after she had it when she was in college. And we had 3 kids. The most she could do, and on the same floor, was the bedroom and the bathroom. To go from the bedroom to the bathroom for 5 weeks. I had to hire full-time help.
Elsie had it last semester.
Did she? Yeah, young people can deal with it better than adults.
Her fever, I think she had for probably 2 weeks straight, I think she had a fever of 104.
Oh yeah, you're freaking sick. And for adults, it's worse.
She was up for, I think she would be awake for 15 minutes, then she'd nap for 5 hours, and it would just be
it was like, I was in practice. A lady who I treated members of her family, who for the 8 hours I was gone, she cleaned, made sure the kids got to school, blah, blah, blah. I came back home from practice, I'd take care of the kids, bed. All it was a mess. And so everything else after this, let's stop it here. I mean, platelets will be fun because this will dovetail more into what we're doing, getting ready for the lab portion, the platelets, and that type of thing. Because platelets are somewhat complex. There's not a lot to them. We talk about hemostasis, and that leads us into the clotting cascade. And once we're done with the clotting cascade, there's where it ends up in. Then we start looking at the other stuff vis-a-vis really a lot of the science about blood transfusions and things like that. Thank you. Enough listening to me. Besides, my kid keeps calling me annoyingly. He's the one who's this is the one just got back from Points Mediterranean.
Really?
Yeah, he's back now.
That's exciting.